I believe we can start.
Hello, good morning. I'm Mary Stephen. Welcome to the WHO Africa Media Briefing, which is taking place in collaboration with the APO Group. First, some housekeeping. We have translation in Arabic and French today. You can choose the language you would like to hear for the press conference by turning on the globe on the bottom right of your screen and select your language. François, please explain in French.
Bonjour à tous et merci d'être connectés pour ce point presse. Vous pouvez choisir la langue que vous souhaitez entendre. Nous avons aujourd'hui disponible l'anglais, le français et l'arabe en cliquant sur le globe traduction en bas dans la barre d'outils de Zoom. Pour vos questions, merci d'utiliser la fonction pour les questions et réponses et merci de préciser votre nom et le média pour lequel vous travaillez.
Merci François. Halim, please explain in Arabic.
أهلا ومرحبا بالزملاء الصحفيين للحصول على الترجمة.
Welcome to the journalists in order to receive the translation or the simultaneous interpreting into Arabic. Please press the globe which is present at the bottom of the page towards the right. And also for questions, please press the Q&A icon and please mention your affiliation. Thank you. Thank you, Halim.
The Republic of Congo is Dr. Mashidisho Moeti, the WHO Regional Director for Africa. Welcome, Dr. Moeti. I will now let Dr. Moeti introduce the other panelists.
Thank you very much, Mary, and greetings and welcome to all the journalists and colleagues who are joining this press conference. Bonjour et bienvenue à tous nos collègues journalistes. So I'm very pleased to be joined today by Her Excellency Dr. Hala Zaid, the Minister of Health and Population of Egypt, which was the first country in Africa to detect a case of COVID-19. And Her Excellency Dr. Zaid will share the reflections on Egypt's response to this virus over the past year. A warm welcome to you, Your Excellency. Thank you for having joined us. And I'm also very pleased to be joined by Professor Piot, the Director of the London School of Hygiene and Tropical Medicine and a veteran of the fight against viruses, who will share those experiences and speak about his experience as a COVID-19 survivor and about how Africa's experience of this pandemic compares to other regions. Peter happens to have been my boss in the past as well. So a warm welcome to you, Professor Piot. So February 14th marks 1 year since the first COVID-19 case was confirmed in Africa. So today we're going to look back over a year of achievements, challenges, and learning as Africa has responded to the pandemic. In the first year of this pandemic in Africa, more than 3.7 million cases have been reported. And in the coming week, the continent is projected to pass a devastating marker of 100,000 lives sadly lost to this virus. The African continent accounts for only 3.5% of global cases and 4% of global deaths. African countries have risen to the challenge of COVID-19, but at huge cost to national economies, to the livelihoods of families, and to the development of the continent. In sub-Saharan Africa last year, the GDP fell by 2.6%, and the IMF predicts that Africa will be the slowest growing large region in 2021. So the socioeconomic impacts of this pandemic will have ongoing repercussions for several years in African countries. During the past year, Africa has experienced 2 waves of COVID-19. The first was contained relatively effectively with rapidly scaled up public health capacities, social measures like border closures and stay-at-home orders at huge cost, we've already said, but also innovative partnerships, including with the private sector, and the fortitude and perseverance of African communities. To overcome shortages of essential supplies, WHO and partners created, as an example of some of the response activities, the UN Supply Portal, which has shipped more than 3,400 oxygen concentrators, 70 million items of personal protective equipment, and 12 million laboratory tests to African countries. Now, the second wave, which appears to have peaked in January, has been far more lethal than the first. Deaths from COVID-19 have increased by 40% in the last 28 days compared to the previous 28 days. The increasing deaths from COVID-19 are a tragic warning that health workers and health systems in many countries are dangerously overstretched. The one-year milestone comes as the continent faces the spread of new strains of virus. Variant B1351, first detected in South Africa, has been detected now in 8 African countries, while variant B117, identified in the UK, the United Kingdom, has been detected in 6 countries on the continent. This week, South Africa announced initially that they would pause the rollout of the Oxford AstraZeneca vaccine because a study indicating that the vaccine is less effective in preventing mild and moderate infection with the new variant that is dominant in the country. The government also announced that they will now use this vaccine, but very much under trial conditions among older healthcare workers so that we can have better data on the impact of this vaccine on more severe forms of the disease. Yesterday, the WHO Strategic Advisory Group of Experts on Immunization, also known as the SAGE, recommended that countries use the AstraZeneca vaccine for priority groups, even if variants are present in a country, while further research is conducted. These preliminary findings highlight the urgent need for a coordinated approach for surveillance and evaluation of variants and their potential impact on vaccine effectiveness. WHO will continue to monitor the situation and provide updates as new data becomes available. We'll also be briefing countries and supporting their analysis of the situation for decisions about vaccine use. While a vaccine that protects against all forms of COVID-19 illness is our biggest hope, preventing severe cases and hospitalizations which overwhelm hospitals and health systems is crucial. If cases remain mostly mild and moderate and don't require critical care, then we can save many lives. So my message is to people, go out and get vaccinated when a vaccine becomes available in your country. Ensuring equitable access to COVID-19 vaccines and sustaining the public health measures are the critical priorities to overcome this crisis. In closing, I'd like to mention that the Democratic Republic of the Congo reported a new outbreak of Ebola virus disease in Bhutembo in the North Kivu province. So far, 2 people have been confirmed with the disease and both have unfortunately died, and 200 contacts are being traced. We, of course, will work with the government to overcome this outbreak as we have done in the past together with our partners. So I'd like to thank you once again for joining us, and I look forward very much to our discussion. Thank you.
Thank you, Dr. Moeti. And now to you, Your Excellency, Dr. Hala Zaid. As the first country to have a COVID-19 case in Africa, could you share Egypt's experience with COVID-19? Over to you, Your Excellency.
صباح الخير جميعا.
Good morning, everyone. Your Excellency, Dr. Machito Moeti,
المدير الإقليمي لمنظمة الصحة العالمية في أفريقيا، السيد الدكتور بيتر بيوت المدير التنفيذي السابق لبرنامج الأمم المتحدة المعني بفيروس نقص المناعة المكتسبة، السادة الحضور. اسمحوا لي في البداية أن أتقدم بخالص التحية لكل من ساهم في تنظيم هذا المؤتمر الهام، وخاصة السيدة ميوتي التي أعتز بدعوتها الكريمة لحضور هذه الفعاليات. وأجدد إعرابي عن خالص الشكر والعرفان للأطقم الطبية في بلداننا الأفريقية التي ما زالت تقوم بدور هام في مواجهة خطر وتداعيات كوفيد-19 تحت مظلة منظمة الصحة العالمية. ما زالت التضحيات التي تقدمها شعوب القارة الأفريقية كبيرة والمسؤولية الملقاة على عاتقها فادحة، ولكننا ندرك حجم والتداعيات ونضع كافة الخطط والسيناريوهات المحتملة لمواجهة هذا الفيروس القاتل. السادة والسيدات، اسمحوا لي أنا مش هلتزم بشكل كامل بما تم إعداده من كلمة، ولكن أود أن أشارككم خبراتنا في مصر وإحنا كنا أول دولة تسجل حالة يوم 14 فبراير 2020 في قارة أفريقيا، وقمنا وكانت أول دولة من أول 3 دول في العالم استجابة لنداء رئيس منظمة الصحة العالمية يوم 7 يناير 2020 لمزيد من الإجراءات الاحترازية في نقاط الدخول وفي المطارات. فكان مطار القاهرة والحجر الصحي في مطار القاهرة من أول 3 مطارات استجابة. خلال قيامنا بإدارة الجائحة كان عندنا وضع
During COVID-19, we had a specific case. We have over 100 million people, where 7 million cases are non-Egyptians. We don't call them refugees, but they are part and parcel of the Egyptian community. Accordingly, it was important to take precautionary measures in the preventive medicine, and we didn't have to put scenarios following the other countries. If the pandemic started in China and some European countries, and as well as the USA and Europe, and they followed specific precautions, we didn't want to follow those countries. We have scenarios where we had to respect the culture of the community and the economic dimension, well as to maintain the souls and to save souls. Hence, we followed targeted surveys and not collective surveys. We conducted PCR for cases that had symptoms, and we still follow this direction. And we did not follow complete lockdown. There was what we called partial lockdown, and this went on for 1 month, and this started as of 7 in the evening up till 7 morning in the following day. We did not stop any economic activities or industrial activities. And there was this balance between life as well as the precautionary measures. And this was successful in managing the crisis and in elevating and mitigating the socio-economic impacts. Egypt was the second country worldwide in economic growth with positive figures, and we registered 9,500 death cases and 170,000 confirmed cases over this year. That is why we were able to respond in the second wave with the lessons learned from the first wave, and we strengthened home isolation. We did not use over 30% of the hospital's capacity in Egypt in the ICUs, as well in the ventilation and ventilators. We did not stop any surgical intervention, particularly even the early detection program of breast cancer were never stopped. The death cases decreased due to tumors with a percentage that exceeds 30% compared to the past 2 years, due to the fact that we maintained the public health system and did not stop critical medical interventions at all over this year and the year prior to it. I would like also to say that Egypt, via its in Africa, did not stop its assistances, particularly children and chronic diseases, as well as the 1 million initiative of the president to treat patients of hepatitis C. And we also helped countries like Chad, Sudan, and some other countries. Sorry, it's not South Africa, but it is south of Sudan and Chad and some of the neighborly countries. Also, via the African Fund that the African Union has established to counter COVID-19 pandemic, Egypt was able to provide assistances to 30 African countries, including medical supplies and COVID medications amounting to 4 million USD. And there remains the major challenge. As you may know, Egypt has contributed to the clinical trials to produce the vaccines. And I was one of the participants and one of the volunteers in order to work in the clinical trials. And there is the Sinopharm vaccine, which was indeed a unique experience and of pivotal importance, particularly this kind of solidarity in the clinical experiences. Egypt fed
منظمة الصحة العالمية للخروج بأدوية وبروتوكولات علاج، وشاركت كافة معلومات المرضى عندنا تم مشاركتها مع كافة الجهات، وقمنا بنشر كثير من الأبحاث في أقوى المجلات العلمية منها اللانسيت ونيو إنجلاند جورنال أوف ميديسين. يبقى اللقاح والتحدي في أن اللقاحات تستحوذ عليها شركات محددة ودول محددة، وإمكانية أن احنا ناخد الكمية الكافية من اللقاحات ده دور منظمة الصحة العالمية والجافي. وفي هذا السياق أشكر السيد سيس بيركلي رئيس الجافي، وأشكر السيد تدرس أدهنم رئيس مدير عام منظمة الصحة العالمية لإصرارهم على إتاحة اللقاحات للدول المتوسطة والقليلة الدخل. وده أنتج إن إحنا بدأنا إن شاء الله هناخد جزء من اللقاحات اللي إحنا سجلناها في الجافي ابتداء من آخر هذا الشهر. ومع ذلك إحنا الحمد لله تلقينا جرعات 3 شحنات من ساينوفارم ومن أسترازينيكا، وبدأنا تطعيم كل الأطقم الطبية في مستشفيات التي تقوم بمواجهة الكورونا، والآن بنقوم باللقاحات الخاصة بباقي الأطقم الطبية في المستشفيات الأخرى. وطبعا أولوياتنا كبار السن والأمراض المزمنة. أدعو يعني المجتمع الأفريقي وأدعو كافة الشركاء إن إحنا نقوم بأبحاث تضامنية ونتبادل المعلومات والخبرات اللازمة للاشتراك في هذه الأبحاث لمشاركة العالم في الوصول إلى لقاح فعال اسوة بالشركات والدول والمؤسسات الكبرى. وطبعا يهمني جدا إن أنا أشكر منظمة الصحة العالمية على المجهود الكبير اللي قامت به لدعم الدول ومصر منها، وكان أول اختبارات PCR تقوم مصر بعملها كان موجه من منظمة الصحة العالمية، وأول PPEs أخذناه هدية من منظمة الصحة العالمية، وما زلنا بنعمل مع الإمرو بشكل كبير جدا. وبشكر الدكتور أحمد المنذري على المجهود الكبير والدؤوب في مساعدة كل الدول في المنطقة وعلى رأسها مصر. لا يفوتني أن أتقدم بالشكر للأطقم الطبية التي ما زالت تقوم بدور كبير جدا في دولنا الأفريقية لإنقاذ العالم أو إنقاذ شعوبنا، وكذلك كل الأطقم الطبية في كل أنحاء العالم. وأدعو أن القنوات الإعلامية والصحفية أن تبذل مجهود أكبر للتصدي لأي معلومات خاطئة سواء عن الكوفيد-19 أو عن اللقاحات، لأن هذه المعلومات الخاطئة تكون أشد فتكا من الفيروس نفسه. أشكر وأشكر السيدة مدير منظمة الصحة العالمية لإفريقيا والمدير الإقليمي، وأشكر دكتور بيتر بيوت. وإن شاء الله جميعا إحنا مع بعض نقدر في مواجهة هذا الفيروس بإمكانيات الدول الأفريقية المحدودة ولكنها المؤثرة بشكل إيجابي. والحمد لله إن إحنا ندير هذه الجائحة بدون ما نأثر اقتصاديات الدول في الأنشطة. أخيراً بذكر أن مصر نظمت الشهر الماضي بطولة كرة العالم، كأس العالم لكرة اليد، ولم تسجل أي حالة إيجابية في ال 32 فريق أو الأطقم المساعدة أو القائمين على البطولة، وعددهم 5000 أقاموا عندنا لمدة شهر.
And we had this international and we didn't have any positive cases. And so we brought back all sports activity, the whole world. And with that, man is back and we are back as strong as ever, with strong support. With that, we can come out of the pandemic with no changes. Thank you very much indeed for the kind listening.
Shukran, Your Excellency, Dr. Zaid. Thank you once again for sharing this interesting experience. We have definitely come a long way in this COVID-19 response. And now let's go over to the veterans in the field of virology. Professor Peter Piot, how do you see the evolution of the pandemic on the African continent compared to Europe? Over to you, Prof.
Thank you very much, Mary, and thank you, Dr. Moeti, for inviting me and also to share the platform with Her Excellency. And thank you, and that is really important. So having access to vaccines in Africa and elsewhere is not only a matter of, let's say, of a moral issue of solidarity, but it's an imperative for everybody. You know, until Africans get the vaccinations they need, the whole world will suffer. The Union summit last weekend by President Kagame. So remind me also that this is one of the big geopolitical issues of our time, access to vaccination. And at the moment, the scarcity. There are contracts through COVAX and the African Union of hundreds of millions of vaccine doses. However, the production, the manufacturing is lagging behind. And scarcity is a big enemy of equity. And so we need to really, in manufacturing, including in manufacturing that can happen in Africa, let's not forget that, for example, one of the 4 yellow fever vaccines that are approved and are used in the world is made in Africa, is made in Senegal, you know, by Institut Pasteur. So it is possible to do this, but that requires more, you know, investments. And then finally, I would say it's not only about prevention and vaccination, but also about caring for those who are infected and affected. And Dr. Moeti mentioned the oxygen. And access to medical oxygen is really a key area where inequality reigns. Not only for COVID, but it's something that, you know, for neonatal care, for the many other areas. And I had that personal experience. So I was in a hospital, hospitalized in London close to a year ago. Was one of the earlier people infected, and I survived and I recovered from my pneumonia and infection thanks to you know, and I had severe oxygen deficiency, but thanks to this medical oxygen support. So I'm very, very sensitive to the fact that something as simple as oxygen can save so many lives. And again, that should be produced locally, should be available everywhere. And the gap between, you know, in low and middle income countries of oxygen is one of the defining health equity issues, I think, of our age. And so you know, 33% of COVID-19 deaths and 75% of child pneumonia deaths could be, you know, saved through this just availability of oxygen. So looking forward, I would say to conclude, COVID has amply demonstrated that we can't afford to create a fire brigade once the house is on fire. That's why we need a WHO. That's why we need public health institutions in between these crises. And we need to invest more. So I hope that this is also a wake-up call for the world to get serious about the threat of epidemics and their prevention, because the risk is that we will have more and more pandemics because of climate change, the destruction of nature, the interaction with with animals, because these are zoonoses, and so we have to to all work together. Thank you so much, and merci beaucoup, et je suis aussi prêt à répondre en français. Thank you very much.
Merci beaucoup, Professor Piot. It is indeed a great privilege for us, drawing from your wealth of experience dealing with outbreaks for decades. Thank you very much. We are joined by our colleagues, Dr. Richard Mihigo and Dr. Nsenga Ngoi from the WHO Regional Office for Africa. So now that you've heard all the panelists, it is your turn to ask your questions. To do this, please use the question and answer function on the Zoom application. Please remember you will need to give us your name and the name of the news media you represent to have your question asked. We only take one question per journalist due to the volume we receive. And please indicate if you would like to go. Is Foster from DPA. Can you please ask your question?
Thank you very much for the briefing. Can you hear me?
Yes, go ahead.
Great, thanks so much. Dr. Merti, after South Africa has halted its rollout of the AstraZeneca vaccine, its neighbor Eswatini also announced that it would stop its procurement of the vaccine through COVAX because of this recent efficacy study. So my question is, are you concerned that more countries will follow suit and reject the delivery of the AstraZeneca vaccine through COVAX, which is due to come in the next weeks? And just a quick second question, you mentioned 8 countries have detected the South African strain. Could you please clarify which 8 countries? Because in the previous briefing with Dr. Nkingasong from the Africa CDC, he spoke of 7 countries. Thank you.
Okay, thank you very much for those questions. I think, first of all, with regard to countries' reaction to the news about the so-called South African variant and the impact on vaccine efficacy, it's to some degree to be expected. And we are working very quickly to brief the countries, to provide them with the SAGE recommendation, which only came out yesterday. So the Eswatini announcement was made before this recommendation came out. It is our intention, and we've already started to send this information to all the governments to contact them and advise them, and to highlight the fact that an analysis of the risks and benefits with regard to using this vaccine needs to be made if this virus is not circulating very widely. And even if it is, we are recommending the use of the vaccine with an understanding that it may not be able to stop some cases, particularly milder cases, but it is able to stop a problem of severe cases. And it just so happens that Eswatini is one of the countries that is experiencing a second wave with very relatively high mortality rates. It's a small country, its health system is struggling to cope with countries. So with the cases. So our intention is very much to contact the government through our office and to provide this advice, not only to Eswatini, and particularly to the neighboring countries, to South Africa, where the interaction is very intense. And we certainly know in several of those, this variant is circulating. Well, of course, supporting and advising all the countries in the region so that the opportunity to benefit from this virus is not lost. So the countries in which this so-called South African variant is circulating include Botswana, Ghana, Kenya, the Comoros, Mozambique, of course, South Africa, and Zambia. One country, Tanzania, has not reported and is not working on the gene sequencing with WHO, but we are aware that 2 travelers from Tanzania have been found in another country to be carrying this variant. So possibly that's the country that might not have been mentioned by the Africa CDC.
Thank you, Dr. Moeti. The next question is from Nusa from Africa News. And this question goes to you, Professor Piot, and Dr. Moeti can complement. Among all the vaccines available on the market, which one is most appropriate for Africa, given the conservation capacity of African countries and the new variants?
Thank you very much for the question. I think we have to realize that we're at the beginning of several vaccines that will come on the market. And at the moment, the ones that are authorized are the messenger RNA vaccines by Moderna and BioNTech Pfizer, which have the highest efficacy. But the logistics can be quite complicated. And that may be okay. I mean, we shouldn't say, like some people saying that it's impossible to vaccinate people in Africa because you need a cold chain or even minus 70 or so, because that's been done exactly with the Merck vaccine against Ebola that has been used on for hundreds of thousands of people, and it's also to be preserved the same way at minus 70. However, I would say that at the moment, indeed, the AstraZeneca vaccine can be kept at just a regular fridge temperature like other vaccines in the expanded program of immunization. And soon the vaccine made by Johnson & Johnson will also be in the market, which has the advantage of requiring only 1 injection, and which in trials in South Africa that were announced last week showed the very high efficacy, over 85% against severe disease and mortality. It's about
trend. We believe that the increases and the peak of the increases would be by the end of April, early May. And I do hope this wouldn't happen again. But these are my expectations due to the lessons learned. Thank you very much.
Thank you, Your Excellency. Then the next question, we are going live to Lisa from Voice of America. Over to you, Lisa, are you there?
I'm here. Am I unmuted? Because it's been a while since, yeah?
Yes. Go ahead,
okay,
please.
Excellent. Thank you very much. Very quickly on the vaccine question, I'd like to know whether vaccines are beginning to be rolled out in Africa in substantial quantities. Last time I heard you thought that this might be the case. But I'd like to mainly ask you a question about the impact of COVID on efforts to contain the new Ebola outbreak in the DRC. Now, since there is a vaccine available, fortunately, for Ebola, and there now are vaccines available for COVID, do you recommend the use of COVID vaccines along with the Ebola vaccine, that this is something that would facilitate containing the epidemic? It's a very dysfunctional part of the continent, I'm afraid, and conflict and so forth. But do you think that this would facilitate containing the Ebola epidemic? Thank you.
Thank you, Sarah. Over to you, Dr. Moeti.
Yes, so our vaccines being rolled out extensively in Africa, not yet, but we are expecting very soon that to be the case. We have, within the COVAX facility, I mean, first of all, I have to say that there's a couple of countries that have started using the vaccines. These include Mauritius and Seychelles in the African region. And we know that in North Africa, which is our Eastern Mediterranean WHO region, in Morocco, Algeria is about to start as well, I believe. So what we are expecting, though, is 2 things. One, there is, as part of the the rolling out of COVAX, it has been possible to procure some of the Pfizer vaccine for a number of African countries. So 4 countries are about to receive some supplies, not very extensively. However, it will give us the experience of using this vaccine. And then we are expecting that by the end of this month, we will have the emergency use listing of the AstraZeneca vaccine, of which through the COVAX platform, we're expecting to be able to eventually provide 96 million doses. So if you like, the substantive rolling out of vaccines, we expect to start in the latter part of February or early in May. We are working very hard with our countries to finalize their plans for the distribution and delivery of the vaccine. And about 34 of the countries on the continent already have their plans ready. So I'm really expecting that in March, we will start to see the rollout significantly of the vaccine. And then is it possible to do campaigns and interventions for both Ebola and COVID-19 in the DRC? Yes, I do believe it's possible. In the last outbreak in the Equator province, we were working, of course, on preparedness and then eventually on prevention of COVID-19 at the same time as vaccination and the response to that Ebola outbreak there was taking place. What will be needed would be to look at what in addition is needed, for example, in terms of cold chain delivery systems in order to work on these 2 problems at the same time. I do believe it's possible to do so.
Thank you, Dr. Moeti. Professor Peter, do you have anything to add on Ebola vaccine?
No, I totally agree with Dr. Moeti. The one thing I'd like to add is that also for Ebola, we have now 2 vaccines. One that is by Merck that is indicated, recommended for in case of an outbreak to contain the spread of cases, and then another one also by J&J using the same platform, as they say, as for their COVID vaccine that could be deployed as a preventive tool, because ideally all healthcare workers in areas that are vulnerable to Ebola outbreaks should also be vaccinated, and that could be something that we should also think of. And then I totally agree with Dr. Moeti that the effort is the organization, the logistics. So why not give several vaccines at the same time? I mean, I don't think there is any, let's say, biological reason not to do that. And so that's so totally agree. Thank you.
Thank you, Professor Piot. The next question is to you, Dr. Moeti. This question is from Dennis from SABC. Whose responsibility is it to vaccinate refugees, internally displaced persons, and stateless people?
Yes, I think, of course, we know that refugees very often face limitations in accessing healthcare services. But as part of international agreements, it is the responsibility of the host governments, as the refugees are part of the population that host governments that are within their geographic territory. So this is very much in line with the equities of the principles and values of equity that are being promoted at the international level as part of global solidarity. So governments that are signatories to some of these agreements, including to the collective action on the Sustainable Development Goals, accept this responsibility. What I think is also reasonable is, in the interests of equity, for these governments to be supported in order to carry out this function. Certainly, it is their responsibility, and I think it's a little bit also a matter of self-interest. You know, refugees are part of the population, are in contact with the population. So if they are not being vaccinated, they will certainly remain as a source of risk to the rest of the population. In the same way as we are saying, if African countries are not having access to the vaccine, then the rest of the world will be at risk. So there will be a matter of solidarity, principle of equity, but also self-interest in ensuring that the entire population which is in the territory of a country is protected in order for the outbreak to be brought to a close in the country.
Thank you, Dr. Moeti. We have Alex who would like to ask his question live. Alex, are you there?
I am, thank you. Can you hear me?
Yes, please go ahead.
Thank you very much. This is Alex from Reuters in Johannesburg. So my question to Dr. Moeti is, South Africa said yesterday that it could seek to swap vaccine doses that it ordered directly from the Serum Institute of India via the COVAX platform. And the sense is they're swapped for a different vaccine. Do you have any comment on that? What do you think about that proposal? And the other thing is just, is quickly that the leader of the South African trial that found reduced efficacy against mild to moderate COVID-19 caused by the variant said he thinks it's highly likely that the Oxford vaccine or AstraZeneca vaccine is actually effective and could well protect against severe COVID-19 because it's based on a similar technology to the J&J vaccine. Do you think South Africa was a bit too hasty to pause vaccinations, given that we're in a public health emergency? Thank you.
Okay, I think I'll turn the vaccine question over to Richard, just to give him an opportunity to take part in this. The response in relation to the swap of vaccines in COVAX. Richard?
Yes, thank you, Dr. Moeti, and thanks for the journalists. Maybe before to respond to this question directly, the COVAX facility has provision for those self-financing countries to opt out for a particular vaccine that they are offered by the facility for a second choice once they've paid a different scheme of enrollment in the facility. So South Africa, right at the beginning, opted for that particular option. So it is something that in theory, it is possible. To which extent this approach will go up to the end, this is a completely different story because for the moment, the availability of vaccine within the facility, as we know, are quite limited. So I think they can do that on the basis of the agreement that they signed at the beginning. But I think it will depend on the facility to have a variety of options in terms of vaccine. And with regards to the efficacy, I think Dr. Moeti, but we've heard also Professor Piot on the intervention that have highlighted probably the likelihood, but this has to be confirmed by the data of the efficacy of the AstraZeneca vaccine against severe cases and hospitalization, which is the ultimate goal for this vaccination strategy. Because of the similar platform that's the one used by the J&J vaccine. But this has to be indeed confirmed in the data, and we believe hopefully that such data will emerge in the coming weeks to make sure that this vaccine can be rolled out quite efficiently in the country.
Thank you, Dr. Richard. The next question is coming to Moeti.
Oh, sorry, Mary. I just wanted to comment briefly on the second question. Did I think South Africa was hasty in pausing? I think it's understandable that a country would wish to analyze again the situation, the risks and the benefits of a decision that it might take based on data, and then see what is the best way to handle the situation. It just so happens that not only did this variant emerge in South Africa and the findings as we know them to be since yesterday, but also that South Africa happens to be going through a very severe pandemic. It is the worst affected country on the continent. It's a very big outbreak of this disease. And I think and their system, their healthcare workers, they've had many people infected and dying among the healthcare workers. The healthcare system has been severely challenged in some of the provinces to cope. So it is understandable for them to wish to stop, think, analyze, and consider several options of how to continue with the response, with the use of vaccines, trying to get the best impact possible in the shortest space of time. And that they've decided to continue with the trials and the studies and to look for data now in relation to older people, older healthcare workers, is a way to address both, to continue to use this vaccine, not in the way initially envisaged, and to see what they can do to acquire other types of the vaccines and continue with the science of understanding this better, because as we've already said, this is one of the vaccines that are best adapted to the context of an African country.
Okay, thank you, Dr. Moeti, for that addition. The next question is still back to you. This question is from Asahi, from AP. What does WHO intend to do on the increasing issue of COVID-19 in Tanzania? And what did the two travelers who were in Tanzania, the country, where are they coming from?
Okay, thank you. So to start with the second question, these two travelers went to the United Kingdom, I believe, and were identified there as having this variant of the virus. We are in continuous communication with the government of Tanzania at different levels. Of course, we have a country office and a country team, and have made it very clear to the government that WHO is available, willing with other partners to support the country to engage in response to the pandemic, which is what we recommend to all countries to do. We have been in communication in writing at my level as well, at the level of the WHO Director General, and we are continuing simply to offer our support through our country office, working with other UN agencies and sharing all the information that we are sharing with all other countries with the government of Tanzania, and of course also ensuring that through our communications, the people of Tanzania, other stakeholders in the country acquire the information that's needed to enable them to address the situation for the sake of the health of the people of Tanzania.
Okay, thank you, Dr. Moeti. So we are coming to the end of this media briefing. So we are going to give our panelists 1 minute each for their final messages. We will start with Professor Peter Piot. You will answer the question first and give us your final message. There is a question for you. Is Africa experiencing difficulties in the availability of oxygen? This is from Dakar too. Then your final message.
Yes, well, I think so. The data are clear that the oxygen is not available everywhere. So that's, for me, could be part of strengthening health systems and also making sure there is local production. I mean, I don't have the figures here, but my message is, let's say, take the situation serious. I think we need really international solidarity to make sure that vaccines are available. That's I'm special advisor to President Ursula von der Leyen of the European Union, and so there is a commitment to also support Africa as much as possible. Vaccines, I think there will be more and more available, particularly in the next quarter. COVAX has committed to start sending about 90 million doses of vaccines to the continent in the end of February, so that's close. But we need to make sure that it's all, we're prepared for it. And that's the best guarantee also to bring variants under control, because the fewer people are infected and the more are immune, the less the virus has a breeding ground for this. So, but first of all, but I would say great leadership in many countries, not in all, as we heard from Tanzania, for example, but again, my tribute to Dr. Moeti's leadership and what you're doing. Thank you very much for everybody to be here. Merci beaucoup. Au revoir.
Thank you, Professor Peter Piot. Now to you, Your Excellency, the Honorable Minister of Egypt, Dr. Zaid. Your final message, please.
Thank you very much indeed. I would like first to thank you for this pivotal meeting and this very important press conference where we spoke about our experiences. I have some messages which I would like to emphasize upon. First of all, the importance of the support of WHO to all countries to cover the essential medicines and supplies. This is rather crucial in Egypt. Thanks to God, we were able to face the pandemic with essential medicines and with the therapeutics that were developed, like remdesivir was developed also in Egypt. We were able to provide 98% of our needs from the medical supplies and oxygen due to local manufacturing in Egypt. We need this kind of support for all countries so that they would be able to counter the pandemic and to cater for the future essential needs in all diseases. The second message is that not only to focus on the pandemic and not to fall negligent to other interventions so that we don't have other deaths, non-communicable diseases and tumors and cancers, etc. And we further need to focus on vaccines of essential diseases. As we have seen in Africa, for example, there is an outbreak of some of diseases, and there's an increase of some diseases like polio, despite the fact that those countries already announced for years that they have eradicated polio, but polio is back again in these countries due to lack of concentration on the basic immunization programs. The other things that we need to give due concern to providing healthcare to refugees and non-residents, as this is their basic human right, and this protects the community at large. I also think that vaccines are still under trials, even if they are used largely. And I do commend on the efforts exerted by manufacturers, companies, and countries in developing the vaccines. But the vaccines are not the ultimate solution, but it is one of the solutions. And with experience and with the lapse of months and years, maybe there would be an efficacious vaccine for all kinds of variants of COVID-19. I do thank COVAX facility for the great efforts exerted to make the vaccines available for low and middle income countries. And I do thank Dr. Morty for her kind invitation to me to attend this press conference. And it gives me pride and pleasure to be part with you and join with you in any discussions. And finally, I would like to say that I am currently finalizing a contract with one of the companies to manufacture vaccines in Egypt. Egypt have been manufacturing vaccines since 1932. And this contract with the manufacturer would enable the provision of vaccines in Egypt and all African countries with affordable prices. Thank you very much indeed.
Shukran, Your Excellency, Dr. Zaid. And now to you finally, Dr. Moeti, your final message, please.
Yes, thanks very much, Mary. First, again, my sincere thanks to Her Excellency, the Minister of Health of Egypt, and also to Professor Piot for having joined us today. And thank you for having shared your wisdom and your experiences with us and our journalist colleagues. I'd like to thank also the journalists for having joined us and for continuing your work of informing the public about this very important subject. And then just to finish, to say that and add to something that Professor Piot said, it is, of course, a huge global geopolitical crisis that is being navigated. And that partially explains some of the difficulties in translating the intentions and the statements on equity into action concretely. But I think we can only continue to encourage those countries to do so because, in a sense, we're all in it together. All the countries in the world are in it together. All the people in a country are in it together. And equity is one of the biggest drivers of inability to solve health problems in the world. So I think this is a test for all of us. Secondly, since we're pausing at the end of the year and reflecting back, I think one can only reiterate our advocacy for investment in health when we are not in the middle of a pandemic or a crisis, because this is what helps us to build the resilience, the systems that are able to detect quickly, to respond and to contain situations before they get out of hand. And then finally, again, going to appeal to our communities. We know that you are being bombarded with all sorts of information about vaccines that might discourage you from seeking this vaccine. I'd like to encourage everyone who has the opportunity when your turn comes in your countries to be willing to be vaccinated, because this is not only in your own interest, in the interest of your immediate family, but also in the interest of the country and in the interest of the continent. And finally, just a word of thanks to Your Excellency for your initiative to use the production capacity that we know exists in Egypt to produce vaccine for the rest of the continent. We've appreciated very much your country's solidarity with the rest of the continent in other health problems. So I'll stop there and thank you, everybody, for the work that you are doing against this pandemic.
Thank you, Dr. Moeti. A big thanks once again to our fantastic panelists. I believe we have learned a lot today. And thanks to all the journalists that joined us today. So for those that would like to ask more questions in French, our colleagues, Dr. Richard and Dr. Nsenga, will be on hand for the next 15 minutes. Thank you. We have come to the end of the conference. Have a nice day. Bye.
Bonjour, merci aux collègues et aux journalistes. Donc, nous allons maintenant prendre des questions.
Thank you, dear journalists. We will allow you to speak if you wish to.
Allô, est-ce que vous m'entendez, docteur?
Can you hear me? Dr. Mihigo, Dr. Ngoi, can you hear me? Yes, we hear you very well. Yes, we hear you. We do not have a lot of questions today. Maybe we'll have a few later. There's first a question earlier addressed to Dr. Ngoi, Youssouf Amin from Dakar Actu. Dr. Moeti had declared during this press briefing that the issue of the oxygen could become a problem in the region. Youssouf, I would like to know whether our region will also know any difficulties in providing oxygen. Dr. Ngoi? Yes, thank you very much. Thank you, Youssouf. Thank you to all of you. I think that Dr. Moeti, in her answer to the question and in her introduction, had indeed mentioned it. I'm not sure that the colleague had heard her. In many of our countries, we have difficulties in producing oxygen when you have and how to conserve the oxygen. And in most of our countries, factories that can produce oxygen are not numerous, first of all. and you only find them very often in larger cities. So when the demand is strong, the availability of the oxygen can become a problem. And in many of our countries, hospitals, when they are overcrowded by severe cases of COVID that require oxygen, can find themselves in difficulty. Now, we not only do we have problems in producing oxygen, but we need also the equipment to conserve oxygen. When we use them at a patient's bed, we have seen that in some countries, in rural areas, it becomes extremely difficult because you have power outages and so on. So this is a real issue. Peter mentioned it earlier. We need to strengthen our capacity in this field. I think that COVID has really shown that management of these cases can be difficult, and therefore we need to strengthen the capacity of our health system in African countries. Thank you. Very well. Thank you very much, Dr. Ngoy. Dr. Mihigo, there's a question addressed to you. Alioune Badaradi from Intelligence Magazine in Senegal would like to know that among the 8 countries in which is the variants, he hasn't heard mentioned Senegal, whereas we know that the UK variant is present in Senegal. Could you clarify this issue? Yes, thank you for this question. Indeed. Dr. Moeti gave us a list of the 8 countries with the variant B351, which is the South African variant. But it's true that we have data that shows that there is a UK variant in Senegal. Today, we were only discussing the South African variant. Okay, thank you very much. Odile Harvey has a question. She's receiving India-made vaccines. What was the first question, please? Now, the first question is, she would like to know which African countries are going to use Sinopharm and Sinovac, the Chinese vaccines. Well, for the first question, as regards to 2 Chinese vaccines, I can mention Seychelles that have started their vaccination on the 10th of January. They're using the Sinopharm vaccine via the United Arab Emirates. 50,000 doses were used in the country. Whereas the other countries that have used vaccines are using mostly AstraZeneca. This is the case of Mauritius, but also Morocco. Morocco using AstraZeneca, and Egypt, of course. And lastly, Algeria, which is using Sputnik 5, the Russian vaccine. Now, for the second question, if you could repeat it, please.
Oui, elle voudrait savoir quels sont les pays.
They would like to know what are the countries that are using Indian vaccines. Now, for the only vaccine you can get via COVAX is the AstraZeneca vaccine, which is manufactured in India. So the vaccines arrived in South Africa, were coming from AstraZeneca, but they were manufactured in India. This is the case also of what happened in Mauritius, Morocco. As regards vaccines manufactured in India, there's a strong cooperation between India and AstraZeneca and Oxford University. Another question, Mr. Mahongo from CDEF. It's a bit technical question. He would like to know that is it possible to have a stricter surveillance genomic of the genome in different countries where the capacity is not always very strong in these countries? Dr. Ngoy might answer this question. Yes. First of all, the genomic surveillance is very important for viral diseases, not only for COVID-19. Even those of you who know how we combat polio know that. As you were told, viruses mutate all the time, and therefore we have to determine if there's a mutation that might have an impact on the transmission mode or on the severe cases of the disease. Now, as regards this question, I'll be direct. I'll say no. In a number of African countries, you do not have the capacity to monitor the appearance of a variant. And this is the reason why WHO, including CDC Africa, have established the African networks for surveillance of these variants. This is a way to support countries who do not have the capacity to monitor the mutations and still have access to sequencing via a network of labs in another country, for instance, in Africa. WHO, for instance, has worked with a number of countries where samples were sent from one country to another, from Comoros to Kenya, for instance, or to South Africa, in order to carry out sequencing. So through these networks, you can sequence samples that come from different African countries. This is the short-term objective. As for the long term, we hope that we can build capacity in the long term in each country, and this is what we're working at. And before this press briefing, we had a meeting where we discussed this issue for the long term. So WHO hopes to be able to develop this capacity in most of our countries. Thank you. Very well. One last question. It's a recurring one. How do you explain the quick spreading of the South African variant? And how can you explain that? I'll try and answer, and then perhaps Dr. Migo might supplement my answer. First of all, the disease itself, in general terms, it's a viral disease. The severity depends on three. First, the virus itself. You have viruses that are more aggressive than others. I don't want to go into the details, more aggressive than others because they have the capacity to infect or to introduce themselves into the human, and they can propagate themselves very quickly, and therefore, and to attack cells and tissues. So this is one of the aspects, the virus itself. And the second element is that the person itself, the person who is infected, if if someone who is vulnerable, who's had other medical conditions, we speak of comorbidity, because if you have a chronic disease, if you already suffer from a disease that has reduced your immunity capacity, well, that person will be more vulnerable to that virus and will develop a severe form of the disease itself. Now, if we speak of mortality and not aggressiveness, mortality of those infected by the virus can also depend on the character of the person, the character of the virus, but also by the treatment, the quality of the treatment provided. So you can be healthy, you can be strong, the virus can be as aggressive, but if the treatment provided is not of good quality, you will develop a severe form of the disease. So these are a few of the factors that determine mortality and aggressiveness. Did I miss the second part of the question? Dr. Mehigo, would you like to supplement? No, I think Dr. Ngoy has explained everything you need to know. Perhaps I could add one small thing. Yes, it might be surprising, but as we mentioned it during the first part of the press briefing, we know that if we don't do something very quickly in order to stop the spread of this virus, we will see in the future different variants of the virus, because it's in its nature, especially the ARN viruses. It's very important to mention it. 40 years after the discovery of the first HIV case, we are still not capable of producing an efficient vaccine against this disease, because of the nature of the virus itself and its mutations. So the message I would like to deliver regarding this is to see to what extent we can vaccinate very quickly a large number of people, so as when we have the data, we can stop the spreading and not give the opportunity, the virus an opportunity to mutate, to change, and infect even more people. And unfortunately, not be the target of our interventions or actions. So it's a worrisome situation for which we need to vaccinate very quickly, so that we can protect a large number of people very quickly, so that the virus does not continue mutating. Another word, please. Yes, for the second part of the question, why Africa is less by this virus. I've given you the three factors that determine mortality. And if you compare Africa to the other regions of the world as regards this virus, because we did say that the mortality is determined by the type of virus, but for viruses, we share the same virus as other regions of the world. But for the lethal character of the virus, we see that mortality is relatively lower on the African continent. So even if it's the same virus, the situation is different in Africa. So the second factor would be the human factor. For now, we do not have any data showing that Africans are more resistant than others to the virus. Now, if you look at a country like the United States with different ethnicities, you see that African Americans are harder hit by the disease there than in Africa. Now, when you examine the situation, we can also see that our health systems are not as strong as others, so we should have had a strong mortality. So what's the reason behind this paradox? So the answer is, first of all, if you have all these vectors converging, the factor that determines the spread of the virus and its consequences in terms of mortality and morbidity is human action. That is the determining factor. Peter told you earlier that early action, decisive action, will determine the quality of our response. And we think that Africa, at the beginning of the pandemic, had the capacity to have a decisive and strong response. There are other factors, obviously, which we haven't studied yet, which haven't been established yet. There are a number of hypotheses about herd immunity and so on. We have studies that have contradictory conclusions and so on. So for the time being, it's not a scientifically established fact. So research has to continue to try and understand these factors that would explain that Africa was hit less harder than other continents, besides the human action and the measures put by governments. Action is not enough, but you have to also have action at the right time, which we did. Very well. Thank you, Dr. Ngoy. Thank you, Dr. Mihigo. Thank you, all the journalists, especially Mahungu, Odile Harvey, and all the others that sent us questions. Thank you to our experts, and we will stay in touch if you wish to obtain more answers to your question. Thank you, Dr. Mihigo. Thank you, Dr. Ngoy.